Hello, I am Karlene Lawrence, the co-director of the interprofessional teams, which is part of the HRSA Bridge GWEP grant on our service. I am presenting Comprehensive Geriatric Assessment for the older adult. The HRSA Bridge grant that we received on our service is to educate the next generation of healthcare providers to provide interprofessional, geriatric-friendly, age-friendly, and dementia-friendly care. I don't have any conflicts of interest. This presentation, Comprehensive Geriatric Assessment for the older adult, is part of our Curriculum A series. Commonly used acronyms that I may use throughout the presentation, which I did already, is HRSA, which is Health Resources and Services Administration, GWEP, which is Geriatric Workforce Enhancement Program, Bridge, which is a Brooklyn initiative to develop geriatric education, the 4 M's, which I'll explain later, the Bridge IT, which is interprofessional teams, which is, as I said, we're trying to educate the next generation of interprofessional providers to be age-friendly, geriatric-friendly, and dementia-friendly. And SLM, which this is a part of, is a self-learning module. The learning objectives for today, for this SLM presentation, is to define the diagnostic and treatment process of a comprehensive geriatric assessment, identify the components of a comprehensive geriatric assessment, which I may also refer to as a GCA, discuss the best evidence for performing a comprehensive geriatric assessment, identify the content on which a comprehensive geriatric assessment is dependent, and identify at least 5 criteria that determine which patients would benefit significantly from a comprehensive geriatric assessment. The 4 M's, which I mentioned before, our grant is based on this format. It's a cooperation between the Hartford Foundation and the Institute of Health Initiatives or Improvement. It's based on 4 principles that we assess all of our patients, our community residents. I may use those 2 interchangeably. The first is what matters. We actually ask patients what matters to them. And sometimes they are so taken aback by a provider asking them that they have no response. But we provide patient-centered care, and what the patient prefers or what matters to the patient and or their family and caregivers matters to us, and we incorporate that into our assessment or encounters with them. Another of the 4 M's is medication. So we assess at every visit a patient's medication. We do a medication reconciliation because that impacts also what matters to them, because it may affect the next 4 M that I'm going to mention, which is their mentation. We also assess that at every visit and may also affect their mobility and keeping them independent at home, aging in place in the community. So throughout the presentation, I'll have some ageism alerts. We're trying to stamp out ageism, as I said, to provide dementia-friendly, age-friendly care. So the first ageism alert that I would like you to think about is negative stereotyping of elders is one cause of ageism, and negative preconceptions related to aging are directly related to poor patient outcomes. A comprehensive geriatric assessment is an interprofessional diagnostic and treatment process that identifies preventative, psychosocial, and functional capabilities of older adults to identify treatable health problems, develop a coordinated plan to maximize their overall health for better outcomes. The components of a comprehensive geriatric assessment all come together to determine the patient or the community resident's functional status, and then that is their medical conditions, what may affect that, support services, social support, psychosocial support, their spirituality, their economic status, the environmental status that they live in or their neighborhood is in, and their cognitive status. And that all comes together to impact their functional status. The structural approach, so a comprehensive geriatric assessment has 2 major structural approaches. The first is multidimensional, which is the physical health, their medication and pharmacy, one of the 4 M's, their cognition, again, one of the 4 M's, which goes with mental health, their functional ability, their psychosocial environments, their psychosocial conditions, and their socio-environmental conditions. There's also the other major part of, or other major structural approach to a comprehensive geriatric assessment is interprofessional. Geriatricians, physicians, physician assistants, nurses, all specialties come together to ensure positive patient or community resident outcomes. The geriatrician or psychiatrist would be involved in nursing, as I said before, NPs, nurse practitioners, RNs, and social workers, nutritionists, physical therapy, occupational therapy, definitely caregiver and family support, and spiritual and religious support. A comprehensive geriatric assessment can be performed anywhere. In the home, as we're doing right now with remote or telehealth patient visits. In a healthcare facility, which is acute, which would be inpatient care or outpatient clinic or department. At a community or a senior center, an adult day program, a skilled nursing facility, a long-term care facility. So as I said, it could be performed anywhere. The content of the assessment varies and is dependent on the healthcare setting. The best evidence or reason for a comprehensive geriatric assessment is identifying appropriate individuals or patients or community residents who would derive the most benefits from having a comprehensive geriatric assessment. The qualifying criteria for a comprehensive geriatric assessment is identifying factors for individuals, as I said, who would significantly benefit from a GCA. And that includes their health or medical comorbidities, for example, heart failure, diabetes, high blood pressure, whatever their diagnosis may be. Their psychosocial disorders, which is either depression, isolation, food insecurity, housing insecurity. Specific geriatric conditions, example, their age, their mental condition, or if they have dementia, which would or could predispose them to falls, or their functional status, functional disabilities, which will include their ability to complete their activities of daily living or their independent activities of daily living, which I will address later. Changes in their living situation, for example, going from independently living in the community to living in an assisted living facility, requiring in-home assistance from, for example, a home health aide, or being admitted to a long-term care or a skilled nursing facility. Inpatient referral factors for a comprehensive geriatric assessment includes referral for preliminary screening to determine whether a full interprofessional evaluation is required. Older adults admitted to a medical or surgical, for medical or surgical reasons, example, fracture, failure to thrive, whatever brings them into a healthcare facility, recurrent pneumonia, pressure sores, etc. Individuals age 65 years and older, actually older adults, which is what we're calling our seniors now, instead of saying geriatric or seniors, is defined as an adult 55 years and older, and a senior is starting at age 65 years and older. So individuals who score high on a threshold of screening that's predictive of hospital readmission. So there's various screening tools that we use, which I will cover later on, and depending on how they score, high or low, normal or abnormal, would indicate whether they require further assistance, whether they could continue to live on their own in their homes in the community, or whether they should be admitted for inpatient assistance or inpatient continuing care. Outpatient referral factors for a comprehensive geriatric assessment include individuals with multiple health issues or problems identified during a geriatric screening assessment, individuals with major illnesses that require hospitalization, or increased home resources to manage medical and functional needs, specifically, as I mentioned before, their functional status, their fall risk, their cognition, or if they have mood disorders, have been diagnosed with mood disorders. The Comprehensive Geriatric Assessment outpatient exclusion factors. So we would not assess patients for a comprehensive geriatric assessment that have a terminal illness, severe dementia, a complete functional dependence, so they're not independent in their home. They may be in home, but they have assistance and they're totally dependent on the assistance to complete their ADLs or their IADLs. Inevitably, skilled nursing facility or long-term care placement. So they're currently may be outpatient living in their homes, but imminently they will be admitted or recommended to be admitted to a skilled nursing or nursing home or assisted living facility. And these individuals are generally deemed unlikely to benefit from a comprehensive geriatric assessment, and therefore they're excluded. This, along with the ageism alert, which I mentioned before, I also have what's called brainstorms. These are little questions that I pose that I give you an opportunity to think about and come up with an answer, or just learning something new that we want you to be aware of as part of our grant, as part of our interprofessional training. How can healthcare providers learn to recognize our own implicit biases, stereotypes, and misconceptions about older adults? We need to be aware of these to provide better care, to provide age-friendly, dementia-friendly care to our older adults or community residents.